Thank you, Carolyn. All right, I have right at the top of the hour, I see we have lots of folks that have joined us, and that is so exciting. So we won't waste any time. We will jump right in and get started. I do want to welcome everyone to this very important webinar on as we talk about telemedicine services and state Medicaid updates. And today we're going to be focusing on Illinois, Kentucky, Missouri, and Tennessee. We did the other 4 Delta states last week. We covered those, so that will be recorded, and both sessions will be sent out for those who weren't able to attend today. And my name is Kim Mayo. I am a program specialist here with the DRCHSD program, which is providing this webinar today. Many of you are already doing that, but if you can find that chat box, which is at the bottom of the screen, and take a minute and tell us your name, your organization, your title, what you do there, that really helps us to get a good feel of who's in the audience today. We really enjoy that. And of course, we always encourage discussion and any questions, so feel free to use that chat box. Come off of mute if you have that availability, and interact with our speaker. We always love to hear from you and your needs and kind of what you guys are thinking. If you're not speaking, we do ask that you put yourself on mute. That really just helps to cut down on any feedback and gives the full attention to our speaker. The next slide is our funding statement that you should see on everything. And that is just a reminder that we are funded by the DRCHSD program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. And not to take away from the importance of today, but just to let you know what is coming up. We do have a quality improvement series, and you can see those titles listed there. That is starting very soon in April. So we'll be sending out notifications about that upcoming series as well. So you won't want to miss that. Also, there are ACHE credits available for today's session. In order to gain those ACHE credits, Caleb Lazinski will be sending an email at the end of the week with a survey link that should be completed. So you should be seeing that very soon. All right, so before we jump into today's presentation, I'd like to start with our pre-polling questions. So Caleb? If you don't mind pulling those up, perfect. All right, so we have one question today. So we would like to understand your, and you can rank there, your understanding of updates that were made to the telehealth billing and reimbursement guidelines due to the COVID-19 public health emergency. So you see you have some choices there. You can click on whether you're confident, somewhat confident, neutral, somewhat unconfident, or unconfident. And we can leave that up as I introduce our speaker just to maximize our time today. So it truly is my pleasure to introduce Heather Green. Heather is a member of BKD's Healthcare Performance Advisory Division. She has nearly 20 years of experience in healthcare industry with extensive experience working in a variety of key healthcare information management roles. She works with hospitals in evaluating and improving their clinical documentation integrity programs. She provides coding and documentation training to improve clinical documentation integrity and coding accuracy. She has lots of certifications and she has lots of accolades. So she is a registered health information administrator, a certified inpatient coder, a certified documentation improvement professional, a certified professional medical auditor, and a certified professional coder. She holds designations of approved CDI and ICD-10 M/PCS trainer. So I apologize if I messed up any of those. Those are way beyond anything that I even understand. So I'm glad you have that, Heather, and I'm glad that you have that knowledge and expertise. And we'll let you share your slides and take it away. So thank you.
Give me just a minute. And thank you for that lovely introduction. And truly, it's a matter of I have to learn it, so I might as well sit for the test. And so it's how many tests you're willing to suffer through for the number of credentials that you'll have is kind of how that works. So let me see, make sure I'm sharing the right slide. And share. So if everybody can see my disclosure here that I have going. I was just thinking about this, reading this disclosure as we're going through it and going, about related to COVID-19, and I really should add, and the changing laws. So all of this information is changing. I can tell you for the last couple of weeks, I have literally been thinking and speaking in run-on sentences, because there are layers upon layers upon layers of trying to explain where something is in terms of that. So please be aware, the law is changing. I hope by the time that we get through this, you'll understand that, there's huge support from CMS on this. And it sounds like we've got Congress who is also in support of these changes. But we haven't seen anything yet come through as a true law. Another thing that I wanted to point out is that I have worked in a community, in a critical access hospital, and so I do understand what it's like to work in a critical access hospital. The one thing I don't know, and I think I said this last time, is I don't know what it is to do it in a pandemic. But I understand that, you kind of do everything. You are what they need you to be in terms of, and they being the patient, whatever needs to happen to keep that facility up and running. So hats off to you all. I know your jobs are difficult, and you all are very needed in your communities. So here's our agenda for today. What we're going to do is what happens after the public health emergency ends. I've got some general information, because as I was studying this and as I've been watching it, I found that understanding how things are going to happen is going to help understand where to look to find those certain things. Then I want to talk a little bit about mental health, because it has taken a forefront, deservedly so, in all of this change as we walk ourselves out of a pandemic, hopefully. So we want to talk about that, and then look at some of these updated state Medicaid guidelines as we know them today, and the telehealth and virtual communications, telephone and audio only communications, and then billing, reimbursements, and questions. Do feel free to ask questions or text them in the chat box. I was able to view it, and for some reason it's not there now. So give me just a minute. Let me put my chat back up so I can see it in case somebody asks something. Okay, so first thing, I think most important, the PHE, the national PHE is set to end April 16th of 2022. So in less than a month, it is expected, that's the date. Now, word on the street is it's going to go for another 90 days. And as you all have watched the news, there's a new variant, surprise, surprise, to a virus. So likely going to go at least another 90 days. Don't know, because this variant doesn't seem to be making people as sick. So even though the numbers are up with COVID positivity, what they're seeing in the ICU and hospital stays are actually, still dropping down. So it's turning more into something that's not necessarily going to put patients in a situation where they have to be in the hospital. Fingers crossed, we'll see how it works. And, it is truly, COVID is following its course of what we would expect from a nasty little virus to do. So we'll see what happens with the pandemic in terms of that, and if it's going to end in April, or if it's going to get another 90 days or not. And then for the particular states that we're looking at, Illinois, you're set to end in April 2nd. I have thought about that and went, probably not doing April 1st, because somebody would think that's an April Fool's Day. But April 2nd, Kentucky, April 14th, Missouri, you all ended yours December 31st of 2021. And then Tennessee, you all ended it November 19th, 2021. And, understanding that from a state side, being able to call in the National Guard to be a part of the process, if they're in working on those kind of things. Or some of the reasons, it's not just healthcare. There's a lot of reasons why a state would want to keep a public health emergency going and not. And so lots of intricate decisions go into making that. Speaking of that, as we're going through this, we have several layers that we have to look at in terms of what's going to happen as we come out of the pandemic. It looks as if it's going to be as difficult to leave a pandemic as it was coming in. I do believe, as I have watched things, that, like I said, Medicare, the Congress, our lawmakers are trying to do things to make that easy, but we've never gotten out of a pandemic before, and we have to give everybody grace. We're trying to do the best that we can do. And I have to believe that our lawmakers and Medicare are with that too. They're trying to do what's right. So how do you know what's going on? Where do you go to look? And we often look, and I can tell you as a consultant and researcher, I often look to Medicare for guidance because they do it well. Most payers follow them, and we can follow suit and see what's going on with that. But how does that work? To make a policy in Medicare, there's actually 4 attributes that have to be addressed in a policy. You have location, and in this case, it's going to be where the patient is located. Modality, how are we providing that service? The provider, which are those of you that are on the call, who can provide that service? And then the service itself, which is what services can be reimbursed. And understanding this, that Medicare only has the ability and has control over this portion of these 4 attributes. Service is the only thing that they can make decisions about, what is going to be reimbursed. The other 3 literally take an act of Congress. So Congress has to pass laws to change these 3 different attributes in order for things to be covered. So if you think about this, if you're RHC or FQHC, or if you have those in your system, if you go back and look, pre-COVID, we have some laws in place, and those laws are pretty stringent, and they're very clear on who can and who cannot do telemedicine. And so we have those laying, and without any change to those rules, once the PHE ends, once the Omnibus Bill, rule expires, we will revert back to those rules. So understand that here's our base level pre-pandemic is where we're at. So we have that layer that we have to be concerned with as of right now. Now, looking at it, we had the CAA that came out. And in what happened here is they're saying mental health can be provided in the home without meeting geographic requirements under certain limitations. So we had this law that came out, it's saying, okay, we're going to take mental health. We know that this is beneficial. We're going to do something with it. Along with that, the fee schedule came out from Medicare, and Medicare changed the definition of the service, which really means it kind of went out a little bit into the gray there, and kudos to them for it. I don't know that they went too much, because if you take a look back to the law, it does say telemedicine. It doesn't actually say that it's telephone or audio. If you look at the law, there's not, the Federal Registrar does not have a definition for that. So basically what they're doing is they've added to the service the definition that there can be telehealth, mental health, and you are to treat that patient as if they're in person. Now, what we need to understand is this law is now a law. However, so we do have one that is post-pandemic. However, we're still in the PHE. So the PHE still supersedes pre-pandemic, and it supersedes post-pandemic. That's a lot of P's in there. So we need to understand that we now, for mental health, we have this covered, but we're still in this PHE currently. With that, if you do have your FQHC and your RHC, They are still now allowed to provide that, and it can be audio only. And so then the other thing that the physician fee schedule said is that there are certain services that were allowed by telehealth during the pandemic, and they're going to continue to allow them to go through December 31st, 2023. So we have that, and there is a link there that I have coming up that's going to go over that. And so going there and going to this website, you can see that there are different categories in the telehealth services. And so just for basic understanding, category 1 is going to be your evaluation and management services or similar services. And category 2, these are other services. And what CMS is saying is they have to show clinical benefit. And they're pretty stringent on this rule. There is more than just the 3 that I have listed here, but in order for CMS to say, yes, this does qualify as a telehealth service, it has to meet some clinical benefit, some pretty structured clinical benefit. Reduce readmissions, reduce recovery time, reduce complications. So if you're ever asking CMS to consider this as a telehealth, you have to be able to prove that this is happening. Then we have the category 3, and that's what's being talked about an awful lot. And this is what's been added during the PHE. And what happened is CMS is saying, hey, you know, we've had this going on for a couple of years now, and we're seeing benefit. We're actually seeing that it's going to meet what's going on here. And so they've also said that this requires more research. They're not really ready to take it away as access for the patient to get to healthcare. And so going out there and understanding what telehealth services are available to you right now and through December 31st of 2023 is really, really important to understand. Now, I mentioned the Omnibus Bill, but I still struggle to say correctly. What is happening is, and when we were looking at this and we were looking at that the PHE was going to end on April 16th, and what do we tell our folks? What do we tell the world out there? Are you planning on, okay, do we have to turn telehealth off? Are we going to do this pause game and, you know, start back up once legislation is passed? Or do we hit the ground running? I mean, so kind of, 3 weeks away, what do you do? And so one of the things that happened is that in the Omnibus Bill, what got passed here is that they're going to expand the current PHE telehealth flexibilities. So the way you've been doing it, they're going to extend it 151 days past the end of COVID-19 public health emergency. So if we think about that, so if it ends April 16th, 151 days is about 5 months. So April, May, June, July, August, September. So we now know at minimum telehealth is going to go, the flexibilities are going to go until September. If there is that 90 days, so then we have September, October, November. So it could, if it goes out 90 days, so then we could be looking at 90 days. This should give Congress enough time to come in and pass laws that will be permanent laws that would take effect post-pandemic, and they would supersede pre-pandemic rules that are in place right now. So we are still somewhat in a caveat, or in a holding zone, but at least we have something that knows that we're not, next month, we don't have to figure out how we're going to redo everything. And so I've got it here by section number so that you're aware of what the Omnibus Bill says. And you can go out there and find that and know that you're looking for section 301, which is actually expanding the originating site to include the site in which the patient is located, including the patient's home. So this is going to get extended that 5 months. Section 302 expanded the eligible practitioners to furnish telehealth services to include occupational therapist, physical therapist, speech therapist, or speech language pathologist and audiologist. So that's happened, that's in the Omnibus Bill. 303 is extending for the FQHCs and the RHC to furnish to be a distant site provider of the telehealth services. 304 is delaying the 6-month in-person requirement that is of those mental health conditions that are mental health services that are there. The telehealth service is that to be able to do it telehealth, you have to have seen the patient in person within the last 6 months, and you have to see the patient annually as part of the caveats that you have to look at with that. So they're delaying that because if we're still in a PHE, they don't want to make it mandatory that a patient meet the practitioner face-to-face if they're still not comfortable to do that. 305 extends coverage payment for audio-only telehealth services. Again, as we talked about, actually, when you look at the federal regulations, the law did not differentiate between audio-visual and audio-only. That was something that CMS had put in as a caveat. So CMS had defined that, the federal registrar had not. And so this extends the coverage and they're opening it up to audio only. 306 is extend the ability of telehealth services to meet that face-to-face recertification requirement for hospice care, for those of you who have hospice, and then extend the exemption of telehealth services. So they're going to be working on that. And the last thing, which CMS is really already doing, is they're going to have to show utilization and report those findings out. And they're already doing this. CMS is really putting out a lot of good information in terms of they're seeing that telehealth services have decreased readmission rates. So for the hospitals on the call, if you're struggling with your 30-day readmission, this may be one way that could help you limit how many readmissions you get in that 30 days. So taking advantage of that, they're also showing that the telehealth services are decreasing recovery time. It's improving in recovery time. So CMS is putting out this information. It seems like they're pumping it out almost daily, getting this information out to providers, to legislators, to lawmakers, so that they can say, hey, we're on board with this. We are seeing that it is going to function. So keep your eye out for that. That's good information that's coming out. We can see that CMS truly is supporting the healthcare in this arena. We do know that with the pandemic, there was a 6,000% increase in telehealth services. And so it's going to be very hard to put that back in the box, especially when you start talking about our more fragile population, and mental health does fall into that. Having access to your healthcare provider, to your mental health provider is paramount. And knowing that, the lack of transportation, that is going to, that's kind of been a barrier that's been removed by being able to have it telephone or audio. The telephone allows it so that if you don't have a smartphone, if you don't have a computer, that really all you need is internet service, or you need a telephone line and you can get to your practitioner. That's huge. And so we know that there is a benefit to that for our patients, just clinically helping them overcome and heal in their disease process. So prior to the PHE, CMS would only reimburse if it was provided by a qualified practitioner, if it was located in a qualified distance site. So only certain facilities could actually be that originating site. The patient presented to the qualifying originating site, so in a rural area, in an office or a facility in FQHC, RHC. And the parties used technology that was only permitted in a two-way real-time interactive communications, complying with state and federal privacy laws. So it was very, very stringent. This is pre-pandemic is what we were facing. In the PHE, it has, this has been relaxed greatly. So home is an acceptable place of service. So think about this. And if you're reading regulations, if you're reading things, knowing that you need to identify where that patient is, and notice that they use the term home, or they use the term not at home, or there's in a skilled nursing home, assisted living. Make sure you adopt some of that, those definitions into your documentation so that it's really clear. Patient's at home. The patient is, maybe they're at a restaurant where they can get internet access and they can meet, HIPAA requirements. And so The other thing that goes on to this is they're talking about the in-person. So with this mental health, what CMS has said, after the PHE, without any other rules being passed, home is going to be acceptable if the patient's been seen in person, if the patient has in-person visits annually, and it may be to the provider or another qualified person in their practice. So it doesn't necessarily have to, it doesn't have to be, I see this patient, and so I'm the only one that can see them via telehealth or telephone. It can be somebody in your practice. They just need to be seen. With that said, kind of going back to the PHE, the Omnibus Bill, this has been delayed until at least at minimum 5 months after, actually 152 days to be precise, after the PHE ends. Now, the audio only, the telephone, I will ask you to have caution when you're doing it. It is definitely a viable way to get patients access to healthcare, but do be mindful of what you're doing, what you're documenting, and how that's handling. So they do allow it if the patient home is the originating site. Keep that in mind. And remember, if we look at pre-law, pre-COVID, that if you're in the originating site, then there's an expectation of that platform that you'll be using. So if the patient's at home, they can do audio only, and the provider has audio visual capabilities. However, the patient either doesn't have the capability or they do not consent to the video. So know that there are some caveats to being able to use that telephone only. That's very, very important to have that tool in our toolbox, but know when you cannot use that is extremely important. In terms of billing the mental health, these are currently what's going to be happening. Oh, I'm sorry, this will be the law. So after PHE, this will be what you would do based on what the regulation states today. So for FQHC, mental health, you're going to treat that patient, you're going to bill it as if they are face-to-face. What you're going to do now is you're going to use that G0469, just like if they were coming into your facility. Your revenue code is going to be that 900, but what you're going to do is you're going to add the appropriate modifier. Either it's going to be a 95 for that audio-visual or FQ, which is new this year. For RHC, you're going to actually use the appropriate mental health codes. You're going to use revenue code 900 and then the proper modifier with that. If there's a CG that needs to happen, a 95 or an FQ. So understanding that that's post-pandemic, post-omnibus bill, and does not take into play any of the 20-something bills that are in Congress right now to get passed that may change this. So this is what it could be, and to be honest, what it's going to be without anything else happening, though we do see a lot of movement happening. We just don't know what that movement's going to be. So one of the things that have expanded is that place of service. So there's two. The O2 is for when you see the patient outside of their home, and 10 is when the patient is in their home. The originating site, that definition is where the patient is at. And so if you're an FQHC and RHC, pre-pandemic, you were allowed to be the originating site. You were not allowed to be a distant site provider. So the patient would come there and they might be having a video conference with their specialist that may be 4 or 5 hours away. And so that's what it's doing. The other thing with the telehealth that's going on is check for pre-authorization. You may be required to get pre-authorization. And if you think about how things are moving, OT, PT, and SP, most times those do require a pre-authorization. So do check on your telehealth what needs a pre-auth and what does not. So lots of telemedicine modifiers now. We do have the GT modifier. Some of your payers will require that. And then you have the modifier 95. These are slightly different in terminology, just knowing who is going to what, which modifier is going to be really important. The GQ modifier is one that is an asynchronous telecommunication system. FQ is going to be a telehealth service furnished using real-time audio only in the communication technology. And so this is a mental health modifier. Modifier 93 is, again, that synchronous telemedicine service rendered by telephone or other real-time interactive audio-only telecommunications. And then you have the FR modifier, which is when you have a supervising practitioner, that's going to be telehealth. And again, that's mental health specific. So understanding what those are and making sure that in those cases, and the one case that I think of all the time is going to be in autism, is when there has to be supervision in some of the services that are happening. So looking at telehealth services, this is a very broad look at the states that we're going through. Illinois, you're going to allow live video. Currently, it does not allow for store and forward, so the monitoring. It does allow for the patient monitoring. There are private payer laws in existence, and you do have a payment parity law, which means that you should be getting paid at the same rate as you would if it's in person. And right now does not require consent on a state level. You still are required on a federal level. Kentucky, you do allow video, does cover store and forward, does not allow for the patient monitoring. You do have a private payer law. You do have a payment parity law, and it does require consent on these telehealth services. For Missouri, allows live video, does cover store and forward, allows for patient monitoring. Private payer law exists. There's no payment parity law, and does require consent of services. And then for Tennessee, you do allow for live video, does cover the store and forward, does not allow for patient monitoring. You do have private payer laws. No payment parity law exists and does require consent. And so as you're getting into the particular services and trying to define what's going on between state and federal, the one thing I will ask you, because we're looking at several different states trying to understand, okay, you've given us laws, so what does that mean? What do we do? And I think that the lawmakers and the folks that are over this, they're still trying to figure out what it's going to be. So, give them a little bit of grace. And I think the information is going to start coming out as they're starting to figure out how to filter through these multiple layers of law and pandemic. I think we're going to start seeing information come out. And then what we're going to have to ask of them coming back is saying they're going to have to give us the same grace. We've had to wait until you've given us the information. We can't do it the way you want us to do it until you give us that information. So again, for the originating site, we still have the Q3014. So if you are doing that Q3014, make sure that you're doing that. In the independent physician clinic, it's still CMS 1500, place of service, still is going to be that 11. For an RHC, you're going to be in that UBO4 and revenue code 780. And then you could be on the CMS 1500 with place of service too, depending on who you're billing that out. For hospital, it's the UBO4. Type of bill is going to be the 12X. Type of service is going to be the 9. And then you're going to use 510 for your clinic. And then for Medicaids, all of us know that Medicaids all like to handle things differently. So you need to follow what the fee schedule says for your current, for your state Medicaid. So,
hey, Heather, a question did come into the chat. I don't know if you've seen that, but I can read it to you if you want. Sure. Is the code G20225 allowed to be used for mental health visits for telehealth?
Currently, the way that I understand it, currently under the PHE, and then in the Omnibus Bill extension, yes. Unless another bill is passed, that after the PH ends, after the extension ends, that will no longer be a valid code, and you're going to treat mental health as if they're in person. But currently, the way that I understand what is being written and all, all of the information that's coming in, yes, it will be. That was a true yes answer, wasn't it? It's clear as mud. So yes and no. How's that? I'm so sorry. But I do think right now we're still good with that. And we know we have at least until September, likely till November or December. And it may go longer than that. We just don't know how many more variants are going to come out of this little virus. Very good question. The state plan maintains a list of eligible services. So making sure that you go to your state plans when you're looking at this, go to the fee schedules and find out what is going to fall under their fee schedule and how that's where you're going to learn how to bill things out. And right now it's going to cover medical, your mental health, case management, dental, therapy, and school clinic services. Currently, right now, all can still be done through telehealth. Also want to talk about and just bring back up that distant site provider definition. And I think that sometimes, especially with all the rules changing, it can get kind of confusing to understand what a distant site practitioner is. And so really, I mean, it is distant. So you're not with the patient. So the idea of this is that you're a distant site. For your FQHCs and your RHCs, what you need to understand is you're licensed as a facility, not as a practice. So even though you have nurse practitioners, PAs, and MDs in there, you're a facility. And therefore, you technically right now, you can't be a distant site provider because a facility can't be distant providing service. Think of it that way. However, under the PHE, they're understanding that you are practitioners and you can provide that. So currently, understanding what you can and can't do in terms of that. I do think that what we'll see, and there are a number of law or bills in route, some of them getting very close to passing across the board. No, doesn't matter what side you're on. But that they were going to continue to allow RHCs and FQHCs to provide that distant site provider if the patient's at home or other elsewhere, because it's just been such a huge way to get patients access to healthcare. We'll see. We have to wait until it's signed, and then we'll know what's going to happen. You remember that you still have your virtual check-ins, which is your G2010 or your G2012. Making sure that, if you're taking into that, what's going on with that and how you do that needs to be at least 5 minutes. Guys, remember, this is a time-based code, so document your time. And then also, if it can't have anything to do with anything within the last 7 days, any encounter within the last 7 days, or if the patient is seen within 24 hours. So if you're sending it to it, do we apply the modifier G95 to G2025? It's going to depend on your state if you do that or not. I'd have to get back with you on that, if that's okay. If we can talk about that offline, because I think it's going to depend on where you're at. For federal, it's not going to change. So how you've been doing it is how you should do it. Your state may be handling it different starting January 1st. So, or when their PHE ends. So do check with them if you're billing Medicaid. So making sure that you're documenting those virtual check-ins correctly and getting that information in there. That is something that I think is going to be, paid attention to. So just recognizing what the billing is in terms of from state medication plan. So we looked at Kentucky and Illinois, and right now the place of service is the place of service 02 with the GT modifier. Brenda, are you from Kentucky or Illinois? Because then there you have your answer, what it's going to be. And then it's paid under the fee schedule. So, understanding that each rule is going to have, each state is going to have their own sets of rules of how you're going to want to bill that out. If it's going to be the GT modifier, if it's going to be the 95 modifier, I think it just depends. And it's actually dependent on how the law is written, because the GT and the 95 are very similar in definition, ever so slightly different. And it's really going to depend on how your law is written as to which one's going to make more sense in terms of that. It's kind of an interesting little tidbit. At least that's the way it is right now. Kentucky Medicaid. So to bill the service, we're going to have the place of service O2 with a GT modifier. For Missouri, you're going to have a place of services O2 with a GT modifier. For Illinois, you're going to have you're going to use your 99441 to 99443. This is for phone only with the GT modifier. And then Tennessee is going to be you're going to use the CPT codes and the O2 place of service is how you would report those out for telephone only visits. So these are for those ones we were just talking about. The patient consent is required for audio, visual, phone only, and e-checks and digital visits. This is going to be extremely important. Now CMS, it does say that it can be obtained, and furnished prior to the visit, during the emergency period, but also must be prior to billing the service. So pre-pandemic, there was a pretty structured consent. During the pandemic, it's going to be, you can actually get it verbally, and they've given out great resources on readback, so that you can make sure that the patient is consenting to what is happening. And then we're going to see what's going to happen going forward. Currently, what we would expect to see is that the physician, as they're talking to the patient, regardless of if a nurse or administrative got that consent prior, they're going to verbalize it again and make sure that you've got that appropriately documented. I mean, if you think about it in terms of what you send to a payer for reimbursement is going to be that note. And so if you're saying that I should be able to bill the service, you want to make sure that you're meeting all of those caveats that we just talked about. The patient doesn't have access to audio. The patient doesn't consent, doesn't have access to video, doesn't consent to being on video, making sure those things are documented in the chart so that it's clear, big red crayon in terms of what's going on with that patient and why you're doing the service, you're doing it this way. Again, taking a look at this, in your documentation, talk about what kind of service it is. It can be in the header. There's nothing wrong with it being, it can be pre-populated. It can be in that header. Is it audio visual? Is it phone only? Are you doing an e-check-in, or is it, digital or a portal visit? So, make sure that you're documenting what it is. Document the location of the patient and the rendering provider. I think a lot of times rendering providers don't think about that. A lot of times you're thinking you're in the office, so shouldn't we just assume you're in the office? But do remember, during the pandemic, you could have been in quarantine. And so you may have been actually calling from home under quarantine, or, we have seen somewhere, because so many practitioners were ill from, one hospital from COVID, they were actually having physicians from another facility calling over and talking to their patients. So make sure that you're saying where you're at and then saying where the patient is at. Remember those terms: home, someplace other than home. I've seen a lot of times that they'll put in the address. Well, that address could be a skilled nursing facility, or it could be an FQHC. And so working, to make sure, because your FQHC or your skilled nursing home may be an originating site, and they're going to want to bill that. So making sure that you're stating that helps solidify the appropriateness of them billing that originating fee. The names and roles of any ancillary staff that's involved in the case, making sure that you have all of that documented. Of course, your orders. Medical necessity, that's always going to be a big one, making sure, why is this visit? Why are you having this visit? Why does it have to happen? And I think the consents play into that medical necessity of it being audiovisual or audio only, because either the patient doesn't consent to it or they don't have access to it. And so that is the most appropriate level of care that you have for that patient. And then in terms of your documentation elsewhere, it needs to follow the same criteria that you would expect in a face-to-face visit, making sure that you're documenting everything that's going on in there for that patient. Now, I am actually kind of wrapping up here with this. We've gone through it pretty quickly. Wanted to see, are there any questions that we might be able to answer for you?
And while folks are formulating those questions, I know that just things to keep in mind, Kate has put some information in the chat. She's put the slides, a copy of the slides, and then just a reminder that any participating current DRCHSD organizations that do need some one-on-one support coaching for telehealth billing and coding, that is something the program can help support you on, and there's a link to complete a request for that. So that is, wanted to point that out as well. But yes, we'd welcome any questions, comments. Now's the time. Someone came in, do you have any consent form examples for the state of Missouri?
I don't have any form examples now, but I think that depending on your EHR, what I've seen that seems to cover it very nicely is, if your EHR can do it, is think about those components. One, you need to tell the patient that this is audio video, and do they consent to that? And if they don't consent to the visual part, that it's audio only. If then you have to think about where the patient is. And so your EHR is going to have their home address, right? So if there's a way that if you're clicking home or clicking at that address, that it would actually auto-populate either home or other than home for you, might be a way to do that. Also, making sure you're clear with patients that, on the e-checks that you're actually going to, that there is a charge for it, unless you as a practitioner deem it medically necessary for them to come in face to face, in which case, then you can't bill for that because it's going to roll into that 24 hours. And so letting the patient know that. And I have seen some say, which to me, I don't know that it's overkill. I actually like when I'm reading it as an auditor, they'll let the patient know that we can't do a full exam because this is an audio video or audio only call, and just, kind of clicking that thing with a patient so that they understand. And I know, when you think about it, you would think that that's something, again, everybody would know, but not if you're not in healthcare. If you're not thinking about what an exam really is, you may not think through that. So I think some of it is just a matter of, meeting I like the term meeting the patient where they are and helping them understand what's going on, I think is really going to be the big thing. I imagine that once we get through the pandemic, that we will start seeing more form templates come out. I can send over to you, Kim. I'll send over, there's some good links on like readback, to them. And so there's a lot of information out there in terms of, what to say to the patient, and then being able to document what that patient says back to you to make sure that they understand what's really happening now. Especially if you're working with patients who are younger or older or may have other disabilities that make it difficult for them to understand what's really going on. I could very well see patients not understanding why they're getting a bill when it's a telephone call. When before pandemic, they never got they called they gave you a call, they never got a bill for it before. So why am I now? And so I think, some of this is transparency and just helping folks understand what's happening, I think will be very important. But that's what Heather said. So we'll see how far that gets you.
Yeah, any resources that you have that you want to distribute, I'm happy to send those to me, and we'll get those sent out for sure.
Okay.
Yeah. And Lisa says,
Brenda.
Thanks. And Brenda says, Heather, you did a great job and covered everything very well. So, yeah.
I do think that it's here to stay. We'll see what, if that's there, but there's lots of laws out there, lots of bills, and they're all a little bit different. Some of them are temporary and they're kind of kicking that bucket down the road, and some of them are permanent. And so what we really need to be pushing for and talking to your legislators about is making it permanent. Mm-hmm. We know this is successful. And if you think about it, who is going to hurt the worst is the patient. If that patient can't pick up the phone and call you, if they can't come in to see you, they're the ones who are going to suffer. that's going to lead back to readmissions. That's going to, you think about it. Let's say if you have a knee replacement, and then you just call and check on the patient, say, how are you doing? I'm doing okay. It's sore, and I'm noticing that it's a little red. Oh, really? Maybe you might have them draw a line around that red, and then I'm going to give you a call back. It's further along. Well, then you go ahead and prescribe medication right now. You go ahead and put them on antibiotics now, while it's still relatively new, versus waiting. And then you're in a bad situation where you're trying to take care of a huge infection. You can start it earlier. So thinking about things like that, and making sure you pose those questions in a way that the patient can answer that. Because then they're truly, especially if it's telephone, they're your eyes and ears at that point. And so you have to make sure your questions are such that they're able to answer as your eyes and ears when they're looking at whatever ailment that they have.
Wonderful. Let's go ahead and pull up those post-polling questions. I think we have a couple. So we'll assess your knowledge from here. So again, we'd like you to just complete these 2 questions and let us know how about your understanding of the updates that were made to the telehealth billing and reimbursement guidelines due to the COVID-19 public health emergency. And after you've listened to the presentation. And then secondly, we'd like to know that if you're confident or somewhat confident, neutral, or somewhat unconfident in how you will apply the knowledge gained from the training, the educational training, to improve your organization's telehealth billing and coding processes. So we'll give you all just a little bit to complete those. And we just want to thank you all again. We do have a few minutes, so I don't want to, if there are any last minute things, I definitely don't want to cut you off, but I do want to thank you all for joining us today. And I want to thank Heather. We will get these presentations recorded to our website and get that information sent out so that can be distributed and shared with the folks who were not able to attend today. Yeah. So anything else? You're getting lots of thanks, Heather. Great info. Thanks. Yeah, looks like we've definitely have some knowledge gained there. So that's a great thing as well.
Well, it's fair, given that we really, there's a lot that everybody doesn't know. So know who to look to and look for, and talk to your legislators and get them to understand that this is something that really needs to get passed. We know this is successful. It's no longer we think, or it could be. We just know. And so we need to push our legislators to get them to understand that.
Yes, and that's what Teresa had echoed. Send out to the group if the bill comes up for vote. So distribute that. Yeah, absolutely. All right. Well, Heather, we thank you so much for your time again today. And if there are any further questions that come up, feel free. We at the Delta program are always willing to help and assist and get the right information and the right time. So reach out to any of us. And we thank you so much for joining us on this Thursday. Hope the rest of your day goes extremely well. And we'll talk to you all soon.